Dysphagia. Dysphagia refers to difficulty in swallowing and can involve problems with the passage of food or liquid from the mouth to the stomach. It may be caused by neuromuscular dysfunction, structural obstruction, or esophageal motility disorders. Dysphagia is an important symptom that can indicate serious underlying pathology such as esophageal cancer, particularly in older adults. Peak incidence. Dysphagia most commonly affects individuals aged 55 and above. The risk increases with age, GORD, neurological disease, and esophageal malignancy. Pathophysiology. Dysphagia is broadly divided into two types. Oropharyngeal dysphagia, high dysphagia. This is difficulty with initiating swallowing and often due to neurological cause, for example stroke, Parkinson's disease, and motor neuron disease. Esophageal dysphagia, which is low dysphagia, is a sensation of food sticking in the chest. It can be due to structural causes, for example strictures and malignancy, motility disorders, for example achalasia, or inflammation, for example esophagitis. Symptoms: difficulty swallowing solids and/or liquids, sensation of food sticking in the throat or chest, odynophagia, which is painful swallowing, heartburn or acid reflux, regurgitation or vomiting of food, hematemesis, so vomiting blood, and melena, so black tarry stools, which could suggest upper GI bleed. Signs: weight loss. This is common in malignancy or long-standing dysphagia. Anemia. This can be shown as pallor, fatigue, and angular cheilitis from chronic blood loss or malnutrition. Halitosis. This may indicate food stasis, for example Zenker's diverticulum. Epigastric tenderness, if GORD or gastritis is present. Cervical lymphadenopathy. This may suggest malignancy. Recurrent aspiration pneumonia from oropharyngeal dysphagia. Diagnosis: urgent referral, 2-week wait. This is for all patients with dysphagia and aged over 55 with weight loss and any of the following: upper abdominal pain, dyspepsia, reflux. Initial management, if less than 55 with no red flags. Step 1. Lifestyle modifications. Avoid alcohol, caffeine, smoking. Reduce stress, and have smaller meals. Avoid lying down postprandially. Step 2. H. pylori testing. If positive, treat with triple therapy, clarithromycin and amoxicillin and PPI for 7 days. Review after 4 weeks, and if symptoms have resolved, then no further action. But if symptoms persist, then a carbon-13 urea breath test, and if positive, retreat, and if negative, refer for OGD. If H. pylori in the first instance is negative, then empirical PPI trial for 4 weeks, and if symptoms improve, then no further action. If symptoms persist, then refer for upper GI endoscopy. Investigations: OGD, esophagogastroduodenoscopy. This is the first-line investigation. FBC to assess for anemia, chest X-ray if aspiration is suspected, barium swallow. This is useful in oropharyngeal dysphagia, so lower dysphagia, or when OGD is non-diagnostic. And manometry. This is for suspected motility disorders, for example achalasia. Complications: aspiration pneumonia, malnutrition and weight loss, esophageal perforation due to stricture or instrumentation, esophageal cancer if dysphagia is progressive and associated with red flags, benign strictures due to chronic reflux or caustic congestion, Barrett's esophagus secondary to chronic GORD, and anemia from chronic blood loss. Management. By cause: esophageal cancer, surgical resection, chemotherapy and/or radiotherapy, and palliative stenting if inoperable. GORD or reflux strictures. Lifestyle advice like weight loss, smoking cessation, avoiding trigger foods, and PPIs, which are first line, and endoscopic dilation if stricture present. Achalasia. Pneumatic dilation, Botox injection, and Heller's myotomy with fundoplication. Zenker's diverticulum. Surgical management, for example, cricopharyngeal myotomy. H. pylori associated dyspepsia, triple therapy, which is clarithromycin and amoxicillin and PPI. Supportive and adjunctive measures. Nutritional support, NG or PEG feeding in severe cases, referral to dietitian for long-term planning. Endoscopic intervention, dilation for strictures, stenting for malignant obstruction, and foreign body removal if required. Ongoing surveillance, regular OGD for Barrett's esophagus or chronic dysphagia. That was the full video, and there's hundreds more like it waiting for you at finalmed.co.uk. Get over 9,000 UKMLA exam questions, hundreds of animated videos, and our trusted textbook all in one platform designed to make your revision faster, clearer, and exam focused. Start your free 7-day trial today